Well, thanks for your applause. I'm done. So it's always tough to speak after lunch because you're ready for that siesta. So, but I saw there's a huge coffee bar over there, so please get tanked up. So I have this little cartoon, little jumping bean, and I think for all of you that have had young children, you know they're just little dynamos of energy, and all you have to do is rev up their thyroid and they really become hyperkinetic and explosive. So they sort of remind me when they come in of jumping beans. They're just bouncing off the walls, and I usually just have them sit on the table and they just start swinging their legs. I know they're hyperthyroids. I don't really have to even do any testing. But I would like to try to do is just sort of highlight some of the differences in terms of children and adolescents when they develop Graves' disease versus what you've heard most probably over the last day and a half from the expert panel on adults with Graves' disease. And to start with, so we just back up a little bit and just talk about what are the causes of hyperthyroidism, so just increased thyroid hormone production in general in children and adolescents. And this is the one time where as a doctor I can look really smart because over 95% of the time children are going to have Graves' disease. So I can tell parents right up front your child has Graves' disease without really doing a lot of diagnostic evaluation. And I'm just playing the odds. I'm only going to be wrong 5% of the time. The other thing that's also very concerning usually for parents is when you tell them their child has Graves' disease, they all of a sudden think this is a very morbid condition and the end of the line. And so I have to try to explain to them also that this condition is named after Robert Graves, and so this is not a fatal, certainly far from being a fatal disease. And in medicine, we always like to talk about not only what are the most common causes, but then what do we consider the zebras. So the old saying, if you hear hoofbeats, don't think of zebras, just think of horses. And so after Graves' disease, the most likely cause of increased thyroid hormone production is actually a child who has hypothyroidism, or autoimmune destruction of their gland called Hashimoto's. And in the early phases of this process, you release a lot of the stored thyroid hormone that's in the gland. And so they go through this temporary hyperthyroid phase, and then they actually can go into a euthyroid phase or be normal and then become hypothyroid. And sometimes it's a little difficult to distinguish these two phases from Graves' disease right up front because biochemically they look the same. And you've heard about antibodies that are present in Graves' disease, and these can be present in hypothyroidism as well. Another rare form is actually if you get a viral infection in your thyroid gland, you can then also have increased thyroid hormone production. This is a little easier to distinguish because often these children have a very inflamed gland. They're quite tender. They usually have some fever, and those are usually tip-offs that this is what's going on. Rarely you can actually even have a bacterial infection in your gland, which is a very rare cause. I would say over the last 25 years I've been practicing, I've maybe only seen 2 cases of children who truly had bacterial hyperthyroidism. As an adult, you can also have an increased nodule or an adenoma in the gland, which is autonomously making thyroid hormone. This is not as prevalent in children as it is in adults, but it does occur occasionally. There's a rare syndrome called McCune-Albright. This is a genetic abnormality where the thyroid gland actually is making too much thyroid hormone on its own. It's not a nodule. The gland is there normally, but because of the genetic mutation in the gland, it's making thyroid hormone by itself. And so the treatment is going to be a little bit different than what we typically use for other conditions. Now really getting down to the real rare causes, you can have a adenoma in your pituitary gland. So remember the pituitary secretes TSH, a thyroid stimulating hormone which normally regulates your thyroid gland. Well, and sometimes you can have an adenoma that's making excess amounts of TSH, and that can drive the process and make excess amount of thyroid hormone. Occasionally there are some children who take excess amount of thyroid hormone, especially little kids like to get into pills, and pills look like candy. And so most probably about every other year we have a young child that just has consumed their parents' thyroid hormone preparation and maybe taken 30 pills, 40 pills at a time. Fortunately, they usually really have very little in the way of symptoms and problems, and often there's nothing we have to do to treat it. We just let it sort of ride its course to do that. And then more and more, unfortunately, what we're seeing is that there are individuals that are taking sort of herbal products and natural products, and some of them actually have thyroid hormone in them. And so we've had some children who've come who are quite symptomatic because of what's in these natural herbal products, and individuals not realizing they were containing those. There's a rare condition where you have too much iodine and it can cause you to become hyperthyroid, and then in women you can have a tumor from the ovary that's making a hormone that can act like TSH. And this is very uncommon in adolescents. And so in pediatric Graves' disease, this is still a pretty uncommon disorder in general. If you look at chronic conditions in children, it occurs about 0.02%. Just as a reference point, hypothyroidism, Hashimoto's, is most probably almost 60 times as prevalent, and it occurs about 1.2% of children. So by far, in terms of thyroid disorders, we see a lot more children with hypothyroidism than we do with hyperthyroidism. If you look at the children in general, they only account for about 5% of individuals who have Graves' disease in the US. As you get older, and the child then has a higher risk of developing Graves' disease. So if you look at the 0 to 11-year-old population, only about 0.44 cases per 1,000. If you go from the sort of the adolescent, then it increases to 0.59 per 1,000. And so the incidence peaks usually somewhere between about the ages of 10 to 15 years in children. And it's quite uncommon to see a child less than the age of 5 with Graves' disease. If they have hyperthyroidism, then you really have to think some of these genetic causes, which I talked before about as a cause of their hyperthyroidism, because often they can manifest shortly after birth. And as in adults, females are much more likely to have hypothyroidism than males in a ratio anywhere from 3 to 6 to 1. As I'm sure has been discussed over the last couple of days, the cause of Graves' disease is an autoimmune basis, and where you're producing an antibody which can stimulate the thyroid gland just like TSH can do. This has been associated with several genes which are involved in regulation of the immune system called the HLA system, and particularly B8 and DR3. DR3 is important because this is one that also increases your risk of developing type 1 diabetes. And so if you look at our diabetic population, which is much higher in prevalence. So for example, the prevalence of diabetes is about 1 in 500 children in the United States. And about 10% of them actually will have an autoimmune thyroid problem as well. Now most of them again are going to have hypothyroidism, but we also see hyperthyroidism in that group. And often when they become hyperthyroid, they present actually the same time they present with their diabetes. And so we screen all children with new onset type 1 diabetes for thyroid problems. And I would say most probably about every other year we pick up a child who has both Graves' disease and diabetes. We know that the inheritance is not just due to one gene, but there are most likely multiple genes that are involved in causing this condition, and the best evidence comes from that is by looking at monozygotic twins. So if you look at identical twins who have the same exact genetic makeup, only half the time does the other twin develop Graves' disease. And so it suggests not only are there genetic factors, but potentially environmental factors as well, which are important in developing this. And that's most probably true for autoimmune diseases in general. This is also the same sort of numbers we see in type 1 diabetes. So identical twins with type 1, only about half the time does the other twin develop type 1 diabetes. So it's felt that you inherit a genetic risk, and that may be these HLA, B8, and DR3, but then something has to trigger that risk. And that's where, under the broad spectrum of environmental factors or triggers come into play. But nobody really has a good idea of what specific environmental factors there are. There's a lot of speculation, but there's nothing that's really proven. As I was mentioning before, Graves' disease, since it is an autoimmune disease, it is associated with other autoimmune diseases, and so we also look for those in children and adolescents. They can develop either before, at the same time, or after a child is diagnosed with Graves' disease. So certainly type 1 diabetes would be the most common. If you look at another endocrine disease, that's Addison's disease, where you have an inability to make a hormone called cortisol from your adrenal gland. And then you can look at non-endocrine causes, so alopecia, loss of hair, vitiligo, where you have loss of pigmentation of the skin. In dark individuals, you start to see whitening of the skin in patches. And then another where you have a low platelet count, where the immune system is basically attacking the platelets, and that's referred to as ITP, or immune thrombocytic purpura. And so these are the most common conditions which we can see associated with children when they have Graves' disease, although they do occur very infrequently. Graves' disease is also more common in children with Down syndrome, or children who have trisomy 21. And this is true also in Down syndrome. They just have a high risk of thyroid disease in general, so they also have a high risk of autoimmune thyroiditis or hypothyroidism. So the signs and symptoms in children are pretty typical as to what you will see in adults. Weight loss, often despite an excellent appetite. And the important thing to remember in children is that children, if you look at their growth charts, which I'll show you in a minute, they are gaining weight consistently throughout their life. So even if a child has no weight change over a 6-month period of time, that would be an inappropriate weight profile for them. So not necessarily that they have to be losing weight, but that they're not showing and manifesting the typical increase in weight that they should be experiencing. Now, there are children who actually can support their increased energy needs and actually continue to gain weight even though they have Graves' disease. So it's not an absolute that all children have to lose weight or have cessation of weight gain. And only about half the time can you really get a history from the parents that the kids are actually wanting to eat more and sort of clearing out the refrigerators. Especially if you have an adolescent male, it's really hard to tell whether that's normal adolescent male behavior or whether this is Graves' disease on top of it. When you get to the third refrigerator, then you definitely know it's Graves' disease. Sweating is most probably one of the more common manifestations that individuals have. And certainly, and hyperactivity, particularly in the younger children, is quite noticeable. They're really, like I said before, the parents will tell you, these kids are just hyperkinetic. They're just like running through the house, they're bouncing off the walls, they can't sit still. It's very typical. Intolerance to heat. Palpitations, most probably, is not that common. I think part of the problem, certainly for younger children, they really can't even express in words what palpitations really mean, even if they feel them. But certainly adolescent can convey that. Fatigue. Diarrhea is pretty uncommon. Sleep disturbances are not that uncommon. Children really have sort of restless sleep, and so often when they wake up, they still really feel tired. It's also difficult during the school year to distinguish, particularly in adolescents, is this just they're also busy schedules and they're tired, or is this something that's been imposed on them by their hyperthyroidism? Deterioration in handwriting is one that I think has always been very useful. If a child's had it for a prolonged period of time, you can really see how, certainly especially with the girl, the guys it's kind of tough because our handwriting is really crummy to start with. But certainly with the girls, you can see these nice script now sort of deteriorating. Unfortunately now, certainly in high school, people don't write very much anymore. So I guess we have to look at keystroking and see whether there's an abnormality in their ability to keystroke quickly anymore. And for the girls, menstrual irregularities, muscle weakness, and particularly up in the shoulders and in what are called the proximal, the upper portion of the leg, where your hips, where your legs hook up into your hips. And so one of the easiest tests to do is just ask them if they're having problems walking up and down stairs. I have them just sort of squat down and then ask them to stand back up again. I'm glad I can still do it at my age, but and that's a pretty good test to see whether they're getting weakness in their proximal muscles. And then certainly the eye symptoms in terms of just a typical stare versus actually the bulging forward, protruding of the eyes, sometimes impairment of moving the eyes from side to side or up and down. Now I just wanted to talk a little bit about just how sort of Graves' disease affects certain organs in the body, and the kidney is one. And so they can have increased excretion of calcium in the urine, called hypercalciuria. And hypothyroidism is just a fancy way of saying that they can no longer concentrate their urine normally. And so they start to urinate a lot more, and the increased calcium excretion can also cause you to pee a lot more. And so sometimes they're thought to have diabetes because they're peeing more, but they're not drinking a lot, which is a real tip-off that they don't really have diabetes to that. It can also lead to, because they're peeing more, this goes on day and night, and so now they can start having to go to the bathroom more often at night. And in younger children, if they were potty trained, they're 4 or 5, they may start having accidents again in the middle of the night because they're making more urine than normal. So occasionally, just this nocturnal enuresis or nighttime peeing is really one of the first signs you can see in young children with Graves' disease. In terms of the brain, as I said before, it can really impair the ability to concentrate, and they sort of become hyperactive, emotionally labile. Unfortunately, some children have been diagnosed having ADD. It's sort of the diagnosis du jour now in children. And so often it can be missed in that they actually have an underlying hypermetabolic state because of their Graves' disease. Certainly, and they can also have a significant decrease in their school performance and their academic performance because they really have a hard time concentrating. Their mind is just sort of racing all the time, and on top of that, if they're not sleeping well, they're also sleep deprived, and so they're quite fatigued. And so I've had many children and adolescents, unfortunately, who've gone almost a year before diagnosis, and so, in their important high school years where their grade and GPA is really important for them if they want to go on to college, we've had to write letters to schools to get them to recognize that their academic performance was an impairment because of a medical condition and allow them to retake exams and sort of make up that semester and not get that counted against them. In terms of the eye findings, in children, the presence of true ophthalmopathy, depending on how you define that, so it's not just the exophthalmos or the bulging forward of the eyes, but even sort of the redness in the eye, sometimes the swelling can get around the eyelids, and just sort of the typical stare that you see, as you can see in this first picture, is present anywhere from about half to 80% of children with Graves'. The eye disease can actually occur months before the true hyperthyroid other manifestations are present. And so there's some individuals who can be diagnosed early, and actually when you test them biochemically, they're not hyperthyroid. Their thyroid function is perfectly normal. And so you can have euthyroid eye disease in Graves'. But if you would measure those antibodies would still be present at that time. If you have a child that has signs of increased thyroid hormone production and they also have the typical eye findings, then it's pretty easy to make a diagnosis of Graves' disease because there's nothing else that really gives you that combination. And as in adults, you can also see children who have unilateral eye disease, as in this bottom picture where you can see on your left-hand side is a typical eye stare with the upper lid retracted backwards, and on your right side is the normal appearing eye. The skin manifestations or dermopathy are very rare in pediatric patients. I have never seen it yet in an adolescent or a child. And normally it's on the shins, and you sort of have this orange peel texture, which you can see in this picture, as well as sort of swelling, which is referred to as this pretibial myxedema. Why it doesn't happen in children really is not understood at all. But it's, like I said, it's extremely rare to find this in children. But it can affect their growth. So actually children who have hyperthyroidism can have some acceleration of growth. And if you're hypothyroid, the opposite happens. Your growth can be suppressed. But that acceleration of growth has to be, if you're hyperthyroid, for a relatively prolonged period of time. So I would say you wouldn't see it unless someone was hyperthyroid for at least 3 to 6 months. It can also affect puberty, and so that girls with Graves' disease can have very irregular periods. They can be sparse. And boys actually may have an increase in estrogen production and the development of what's called gynecomastia, or breast development. If you look at all males, as they start to go through puberty, about 70% of boys will have a little bit of breast development because they're making estrogen at the same time. They're making testosterone. But as they go further through puberty, they make a lot more testosterone, and that just sort of impairs the ability of estrogen to work, and so the gynecomastia goes away. But if they have Graves' disease, they're increasing their metabolism, and so they're increasing the amount of estrogen they're making, and so you can have persistence of the gynecomastia in the boys. So in terms of treatment for Graves' disease, it's very similar to adults. There really are 3 options. There are anti-thyroid medications, there's reactive iodine ablation, or there's surgery and thyroidectomy. We have a preference in children and adolescents to start with medications first. And as I'll show you, it's because of the natural history of Graves' disease in children and adolescents versus adults. There's a more likelihood of having a remission. Reactive iodine ablation, we'll talk about some of the potential concerns about treating a child with reactive iodine at a young age. And thyroidectomy is usually the last option. There are only sort of a few unique cases where we would consider surgery. So sometimes we have children who have underlying disorders. So if a child had leukemia, for instance, in the past and now develops Graves' disease, then there's a reluctance to give reactive iodine because of their risk of having other malignancies since they've already been treated for one malignancy. Again, children with Down syndrome have a higher risk of developing malignancies, and so we have a reluctance to use reactive iodine in those children. So if they have prolonged Graves' disease now responding to medical therapy, they would be candidates for surgery. So the surgery option is certainly out there, but it's very seldom used. In terms of medical therapy, we know that if you look at children with Graves' disease, and the problem with these numbers are the studies are very small. As I showed you, the prevalence of Graves' disease is already low compared to adults. So it's very difficult to find one center that has a large population of children with Graves' disease. So that really requires having multiple centers across the United States looking at this. The other problem also is that generally the children leave our practice by the time they're 18, and they then sort of get scattered to the winds because there are a lot more adult endocrinologists in the country than there are pediatric endocrinologists. So children have a tendency to be concentrated certainly in major urban areas and in medical centers where they get their care. So we at least have some ability to have some longitudinal follow-up. But once they then become 18 or 19, there are lots of adult providers that can go into the community. And so it's very difficult to then follow them for 20 or 30 years. And most people don't have a career of 60 years to say, do you stay in a permanent remission or do you relapse as an adult? So I would say it's important to take the numbers with sort of a grain of salt. They're not most probably perfect, but it's felt that anywhere between about 34 to 60% of patients who are treated with antithyroid medication can go into remission within 5 years after their diagnosis. As you're familiar with, in the United States, there are 2 antithyroid medications which are available, methimazole and PTU. But in PTU now has this big black box warning because there have been reports of children who've had liver damage and actually permanent liver damage, liver failure, have to go on to get a liver transplant. So PTU in children and adolescents really should never be used unless there's a problem with them tolerating methimazole and really contraindication for giving reactive iodine. So the only medication we use, and we've been using methimazole anyway over PTU, one, because you don't have to dose it as frequently. So with PTU, you typically have to give it 3 times a day. The likelihood of a child taking medication 3 times a day for a week is low, much less for 3 to 10 years. And so with methimazole, we can often go twice a day and sometimes even just once a day with therapy. To that. So we've been using methimazole for a long period of time. It's important to remember that the antithyroid medications do not block the release of the preformed hormones. So once a child is first being treated, that sometimes they can still have a lot of thyroid hormone in their system, and that effect won't dissipate for many, many weeks. So even though you start them on medication, they can still be clinically hyperthyroid, even though biochemically they're starting to improve. And so often if they have a lot of problems with symptoms, then we can add a second type of drug called a beta blocker. Propranolol is the one that we commonly use, or another one called atenolol. And this will help with some of the symptoms. So it will help with the shakiness, the jitteriness, the fast heart beating, the sweating. Unfortunately, it's not going to help with the fatigue. It's not going to help with the weight changes in these individuals. So it will give some improvement, but it's not going to be a cure-all until the medication, the methimazole, starts having an effect. But often we certainly will use, in the beginning, these 2 medications together. And then the downside of medical therapy, one would be that you give too much and you start making someone then hypothyroid, particularly because the natural history of Graves' disease is that some people can go into remission and then it can sort of wax and wane, and they can come out of it and they're on this roller coaster for a while. And so if you're giving them a fixed dose of methimazole, and that's fine when they're hyperthyroid, but now, over that 3-month period of time while you're waiting to see them again, they go into remission, then that dose may be too much for them and they can become profoundly hypothyroid. So we always counsel our children and adolescents and their parents about the signs and symptoms of hypothyroidism are, because they can occur any time when you're on medication. And so hypothyroidism is just basically the opposite. You have decreased energy production, and so you're going to feel fatigue, you're going to feel cold, you get problems with constipation. You can also have menstrual irregularities and weight gain. If it persists long enough, you can get hoarseness because you start to get edema of the vocal cords. And then you can have dry skin, and the dry skin is really not just sort of isolated to the hands or the feet, but it's really dry skin throughout the entire body. A slow heart rate, and then if you tap the reflexes in the ankles and the knees, there's a delay in those reflexes. One of the questions that's always asked is, can children with Graves' disease participate in physical activity because, their body already is sort of racing faster than anybody else, and now you try to increase their heart rate with activity. And our general rule is that we sort of let the child sort of gauge how much they can participate in. I mean, I've seen some children that are floridly hyperthyroid that have been, playing sports and in competitive sports, and they haven't missed a beat. And other children who are just mildly hyperthyroid, and they get into a game in 5 minutes, they're out of energy and they can't run anymore. So I don't think it's very easy just to give a generalized prescription in terms of what they should do for physical activity, but they should be aware that it certainly can impede their ability to be exercising normally. We also give them hope that once we get them under control, they can actually run faster than they were before, but I don't always make that promise. So generally, their symptoms of fatigue and exercise tolerance do resolve with treatment. And as I said, the amount of activity that they're participating in should really be guided by their own tolerance. Fortunately, children have very healthy hearts. They don't have diseases in their arteries of their hearts, so they can tolerate faster heart rates than adults can, and so it's not as much of a concern as it is in an adult. In terms of remission, that is our goal. Obviously, we cannot cure Graves' disease. We can only hope that the treatment sort of runs its course and kids will go into remission. But how many stay in remission after therapy is discontinued, like I said before, is just not well studied because we just don't have good long-term outcome data. Certainly, if you're not going to stay in remission, you're more likely to go back into recurrence of disease, usually within the first year of stopping medication. So our approach generally has been to give medication to children, and we try to keep the dose fixed, and then if they start showing that they're going to remission, then we just sort of back down on the dose. I don't give thyroid hormone back to people because then I lose my marker of ability to tell if they're starting to go into remission. The other key that often children are going into remission is their gland starts to get a lot smaller, and often in the beginning the gland is quite firm, and as it goes into remission, not only does it get smaller, but it softens back up again. And so if I have a child that the gland's getting smaller and I have to continually back down on the dose because they look like they're becoming hypothyroid, usually those are very good indicators that they are going into a remission. As we said before, the remission rate is somewhere between 34 to 64%. I think most probably the real figure is most probably closer to that 35, the low end of that target. If you do go into remission, usually it's within the first 2 years, and then if you go beyond 2 years, your likelihood of going into remission really drops off rather dramatically. As I said before, if they relapse, they have a tendency to relapse relatively early after discontinuing medication. The other reason that methimazole has always been ahead of preference is because it's felt that methimazole actually may have some immune regulatory function as well in terms of helping to get people to go into remission, although I think that there's still a lot of question about the validity of that. Unfortunately, there's no way of telling ahead of time who's going to go into remission, because then it would be very helpful in terms of making maybe possible therapy decisions about whether you want to try medication or just jump right to radioiodine therapy or even consider surgery. But so far, there's been no good biochemical marker or other clinical marker to determine who's going to go into remission and who is not. Radioiodine ablation, certainly the most acute effect of radioactive iodine is that you give too much. And the goal is to try to give just enough so that you can get the gland to become back to its normal state of making thyroid hormone. But unfortunately, there's no really good way of coming up with a good number to do that. So there have been lots of attempts by looking at the size of the gland, looking at the uptake, if you do an iodine scan, and then doing a calculation. But if you follow individuals out long enough, you'll see that certainly if you're doing it in a child who's got another 80 years ahead of them, the likelihood of them remaining euthyroid for those next 80 years has got to be pretty close to zero. So we have a tendency to push the dose anyway and just make sure we just get rid of the gland functioning altogether, and then just give them back thyroid hormone to do that. One of the other reasons is because there is a concern about radioactive iodine. Once it gets into the thyroid gland, can it increase your risk down the road of developing thyroid cancer, because now you've exposed the gland to radioactivity. And so by just ablating the gland and getting rid of it totally, then that doesn't become an issue for individuals. And it's pretty easy just to get someone to take 1 pill a day in terms of thyroid hormone. It's much easier to treat hypothyroidism than it is hyperthyroidism. So we sort of counsel families that we're going to expect them that if they're going to go radioactive iodine, that they're going to end up being on thyroid hormone. It is, though, from the few studies that have been done, and the longest follow-up is about 36 years of 100 children, that there was no increased risk of thyroid cancer in those individuals, and just as importantly, if you looked at the offspring of those adults, that their children did not have an increased risk of having cancer as well. But again, it's only 36 years of data, and we know children are going to live a lot longer than that as well. Where we do have information, and most probably which is a little comforting, is that for these doses, for treating children, we use somewhere between 8 to 12 millicuries of iodine, just to give you an example. For For children that have thyroid cancer, we go up to 100 to 150 millicuries because we really have to get rid of any potential cancer that's left after their surgery. So these children are getting 10 to 20-fold increase. And even with those doses, following children out for 20 years, there hasn't been any significant increase of risk of developing other types of cancers from that exposure. So I think if we do use radioactive iodine in children, the likelihood of them having significant risk is still relatively low. However, the rule right now is that you would not consider treating a child until at least they were about 10 or 11 years old with radioactive iodine. And I think most people are pretty much sticking to that rule. So in terms of monitoring therapy, once someone is on treatment, then we want to make sure that we've got them back into a normal state. So we will measure their total T4, their T3, and their TSH. We typically see children about every 3 months because children are growing, and so their doses are going to change, not only with the change in the course of the natural history of their disease, but because they're growing as well. In adults, it's very different. Once you come to your final height, you only sort of grow this way, not up anymore. So where the drug gets distributed in your body pretty much stays pretty constant, but that's not true for children. The one sort of caveat is that certainly with anti-thyroid medication, you can get the T4 value back in the normal range within a couple of weeks, but the TSH can actually stay suppressed for a long period of time. And so that should not be a guide in terms of making decisions about how to adjust the dose of the medication, certainly for the first year. And I've seen some children have a suppressed TSH for beyond the first year. So the longer they've been suppressed, and certainly the greater extent of that suppression, because the problem is once your level is below the normal range, you can't tell then how suppressed you are. Right? Once you get to zero, that's it, you're at zero. But the gland itself could be really suppressed, and so it can take a long time before that TSH starts to rise back up again. So measuring TSH by itself is not a way of following somebody. In one review, there are about 47% of patients had a permanent remission for the drug over a number of years, and 29% of those individuals had a relapse. Other side effects of medication besides hypothyroidism, one is a skin rash. Some individuals can develop urticaria or hives, but the problem is you can also have hives with Graves' disease. And so I've not let that stop me from using medication. We get concerned when you develop hives because then it's maybe a sign that you're going to have a worse problem where you start to get swelling of your airway. And obviously that can be life-threatening. It's something called anaphylaxis. But often, if you just wait it out, if they only have the urticaria and they have no other signs, then generally the urticaria will go away in a couple of weeks. And so if they're having a lot of problems, we just use antihistamines to help control the itching that they have. But you can push through it a little bit. Because if you don't, then the problem is you're off of thyroid medication, then your only option is to go radioactive iodine. So since you don't have many treatment options, you're sort of stuck a little bit. The one that most people are concerned about is that it can lower your white blood cell count, which is the cells that are helpful in fighting an infection. Now, often it's reversible, but some individuals have profound suppression of their white cell count and can have significant medical problems. Fortunately, this occurs less than most, probably 1% of the time, the severe form. And there's no way of predicting or telling who's going to develop it, and so we don't routinely monitor the blood count because you can't tell when it's going to happen. Although if it does happen, it's usually within the first couple of months of starting medication. So once you've gotten out to about 6 months, the likelihood of it happening it really drops off rather remarkably. We do a blood count at the beginning just to make sure your count's not low to start with and know what your baseline is. But often if they're having this problem, the children will start complaining about having sore throats because often the infections are in the throat, in the tonsils and the pharynx, and high fever. And so any child that has those two combination of symptoms has to come back right away to be examined. They can also complain of sort of like arthritis, the swelling in the joints and joint pain. Usually also this is somewhat short-lived but can persist. And then with methimazole, you can have liver disease too, but not the same liver failure you get with PTU, and it's not of a significant medical consequence when you do that. The other problem too is that often people with Graves' disease right up front, if you measure their liver tests can be mildly elevated at the time they have presentation of their Graves' disease. So it's important to get these baseline studies so you don't start getting confused once you start treating someone and blaming the medication for causing the problem, when in reality they already had this sort of pre-existing. Children and adolescents with thyrotoxicosis are often voracious eaters, and so the problem is they continue to eat at that pace once you start to block them, then they can start gaining weight. And this is actually a weight chart for an adolescent that I followed. So you can see the 50th percentile is just the average weight, and at the blue line, you can see when her hyperthyroidism started, right? So her weight dropped rather dramatically. She wasn't trying to lose weight. And so often individuals are quite happy they're losing weight. She wasn't even that overweight to start with. But certainly children who are overweight are quite pleased that they're losing weight, and so they won't report any symptoms. They're just thinking, well, this is great. I'm losing weight. I don't have to try. I can still go to McDonald's. But the problem comes then, you can see that she sort of hit a nadir in her weight when we started medical therapy. And then her weight went back up. But as you can see in the graph, it went beyond the point where she was initially, and it went up to the 75th percentile. So unfortunately, their appetite doesn't necessarily just cut back just because you start treating them. People start to learn to sort of live at that appetite, and so you have to work hard and forewarn them that it's important that they start cutting back their calorie intake. Also, just threw in a little bit about neonatal Graves' disease. So we actually see children all the way from birth on upward who develop Graves' disease. What's unique about neonatal Graves' disease is they've actually acquired the disease from their mother. Remember I said before, it's rare to see Graves' disease in children under the age of 5. So these children themselves are not producing this antibody that's stimulating their thyroid gland, but they've acquired it from their mother. And so about 10% of women who have Graves' disease will have elevations of thyroid hormones. So 10% of babies, with women with Graves' disease. So the one thing we don't understand is why do the other 90% of infants not have Graves' disease, even though their mothers are making the same amount of thyroid-stimulating immunoglobulin? And so there seems to be, the placenta is this barrier between the infant and the mother, and what antibody gets across seems to vary quite a bit from one individual to another. The other is, I'm sure that you've been told that not only are there sort of stimulating antibodies that people with Graves' disease make, but there are also blocking antibodies that you can make. And so you have sort of this balance, and most people have more stimulating and blocking antibodies, but they don't have to go across the placenta in the same ratio that the mother has. And so it may be that the babies are getting more blocking antibodies than stimulating antibodies, and that's why they don't have Graves' disease. And there are actually some babies who the mother has Graves' disease and the baby comes out hypothyroid, because the baby is just getting the blocking antibody and none of the stimulating antibody. So you can see in the picture up front, the baby is also sort of, if they've had neonatal Graves' disease and it's been going on during fetal development, these babies are also very hypermetabolic, and so often they're quite scrawny when they're born. They're very underweight. You can see this baby is sort of a little gaunt looking, and you can still see the protrusion of the eyes. And in the lower picture, you can see a goiter in a neonate. However, only about 1 or 2% of children will have Graves' clinical symptoms of thyroid toxicosis. So most neonatal Graves occurs in the setting of the mother herself actually having active Graves' disease. However, this can also occur in women who've had thyroidectomies or have had radioiodine ablation therapy, because remember, these treatments are not controlling the antibody production. We have no means of controlling that at this point in time. So even though a mother who's been had a radioiodine or a thyroidectomy many years ago, she could still be producing these stimulating antibodies, and so they will go across and affect the infant. So it's a well-recognized fact, and so mothers with Graves' disease, even if they've had treatment, are still screened, and they'll measure the thyroid-stimulating antibody, the TSI, and and they'll watch the babies very carefully for signs of developing Graves' disease. We've had some fetuses that if they really truly have hyperthyroidism, we've actually treated them by giving the mother PTU or methimazole, and that will cross over to the baby and essentially treat the baby. And then you can give the mother thyroid hormone to protect her. Thyroid hormone does not go across, so that way, because you'll make the mother a hypothyroid if she still has a gland in place. If she doesn't, then there's no effect giving her the medication. And so in practice, hyperthyroidism is most likely due to thyroid-stimulating antibodies. But generally, it's for those that have very high titers. So normally the TSI is the expression of if you have an activity that's 100%. So you have to be 5-fold above that. And these are the mothers that are more at risk of having babies with neonatal Graves' disease. So I've sort of tried to highlight what are some of the differences between children and adolescents. Obviously, right now, we can't cure Graves' disease. All we can do is treat it. And so we've talked about the conventional therapies, and then there are some other approaches. So we can stomp on Graves' disease. We can try to zap it. I'm not quite sure what plucking is, but we can try to pluck it. And of course, the best would be if we could just wipe it out. So thank you for your attention, and I'll be glad to answer any questions.